What are the key differences in the presentation and treatment approaches for autism spectrum disorder as an attention deficit hyperactivity disorder (ASD? Answer: Autism spectrum disorder (ASD) is characterized by persistent deficits in social communication and restricted, repetitive patterns of behavior, interests, or activities. Children with ASD often display difficulties in understanding social cues, forming relationships, and may exhibit sensory sensitivities. In contrast, attention deficit hyperactivity disorder (AHD) primarily involves symptoms of inattention, hyperactivity, and impulsivity. While both disorders can coexist, their treatment strategies differ significantly. Treatment for ASD often includes behavioral interventions, such as applied behavior analysis, which focuses on improving specific behaviors and skills. Early intervention is critical and may involve speech and language therapy, occupational therapy, and social skills training. In contrast, ADHD is commonly treated with stimulant medications, e.g., methylphenidate amphetamines that increase dopamine and norepinephrine levels to enhance attention and decrease impulsivity. Non-stimulant medications like atomoxetine may also be used. Behavioral therapies, psychoeducation, and parent training are vital for both disorders to support academic success and improve social interactions. Discuss the neuroimaging techniques used in the diagnosis of psychiatric disorders. Answer: Neuroimaging techniques are pivotal in diagnosing and understanding psychiatric disorders. Key modalities include magnetic resonance imaging, MRI, computed tomography, CT, positron emission tomography, PET, and single photon emission computed tomography, SPECT. MRI offers high-resolution images of brain structures and is invaluable in identifying structural abnormalities associated with psychiatric disorders, such as the enlargement of the lateral and third ventricles seen in schizophrenia. CT scans are often used for quick evaluations in emergency settings, but have low sensitivity compared to MRI. FRI specifically measures brain activity by detecting changes in blood flow using the BOLD, blood oxygen level dependent, signal. It allows researchers to observe functional brain activity associated with psychiatric conditions like depression and anxiety by examining brain responses to stimuli or during cognitive tasks. PET and SPE. CT provide metabolic information particularly useful for assessing neurotransmitter systems. PET can measure dopamine receptor binding in schizophrenia or serotonin uptake in depression, whereas SPE-CT is often used to assess cerebral blood flow and can identify abnormalities in mood disorders. Collectively, these imaging techniques enhance diagnostic precision and aid in tailoring treatment strategies, thereby improving patient outcomes. Understanding the unique contributions of each technique facilitates a comprehensive approach to psychiatric evaluation. Explain the role of EEG in diagnosing seizure disorders. Answer: Electroencephalography (EEG) is essential in diagnosing seizure disorders. It measures electrical activity in the brain and is particularly effective in identifying seizure foci through abnormal waveforms. For epilepsy, EEG can demonstrate interictal spikes, generalized spike and wave patterns, or focal abnormalities, thus confirming the presence of seizure activity. However, EEG's limitations include variable sensitivity. For instance, up to 50% of patients with epilepsy may have normal EEG results between seizures. This limitation necessitates careful patient selection and the potential for prolonged or ambulatory EEG monitoring to capture infrequent seizure events. Specificity can also be an issue, as EEG abnormalities may be observed in non-epileptic conditions such as encephalopathy or even in healthy individuals, complicating the diagnostic process. For instance, non-convulsive seizures may be mistaken for other neurological issues if not properly interpreted. Thus, while EEG is a cornerstone in the evaluation of seizure disorders, it should be integrated with clinical history, neurologic examination, and possibly neuroimaging for a comprehensive assessment to ensure accurate diagnosis and management. Discuss the sleep disorder Mr. Thompson is likely experiencing, considering his symptoms and the diagnosis process. Answer: Mr. Thompson's symptoms are indicative of REM sleep behavior disorder, a condition characterized by the loss of normal REM sleep atonia leading to physical activity during dreams. This condition often presents with patients acting out their dreams, which can include violent movements as described by his wife. Polysomnography (PSG) is the gold standard for diagnosing RBD. During a PSG study, abnormal movements and the lack of REM sleep atonia can be observed. Typically, PSG for RBD will show that the patient enters REM sleep without the usual muscle paralysis, allowing for physical activity. Moreover, during the test, clinicians can assess other sleep parameters and rule out other conditions such as obstructive sleep apnea, which may present with similar symptoms. Management options for ART-BD may include pharmacological treatments such as clonazepam and behavioral interventions to create a safe sleep environment. Recognizing and diagnosing ART-BD is crucial as it can be associated with neurodegenerative diseases like Parkinson's, making early intervention important for overall patient health. Compare and contrast PET and SPE CT scans in psychiatry. Answer: PET and SPE CT scans are neuroimaging techniques that assess brain function and metabolism, particularly useful in psychiatry. PET offers higher resolution and specificity than SPE CT, allowing for detailed imaging of metabolic processes. It utilizes radiolabeled tracers to visualize blood flow, glucose metabolism, and neurotransmitter receptor availability, which can be critical in understanding conditions like depression or schizophrenia. For example, decreased glucose metabolism in specific brain areas may indicate depressive states, while altered dopamine receptor activity can help in understanding psychotic disorders. In contrast, SPE-CT is more accessible and cost-effective, using gamma-emitting radioisotopes to assess cerebral perfusion. While it generally has low spatial resolution compared to PET, SPE-CT can still reveal important patterns of blood flow that correlate with psychiatric symptoms, such as identifying areas of hypoperfusion in depression. Both modalities contribute to our understanding of the neurobiological basis of psychiatric disorders, helping to clarify diagnosis and inform treatment strategies. For instance, identifying specific metabolic deficits can guide targeted pharmacotherapy, and longitudinal studies using these imaging techniques can help evaluate treatment efficacy and disease progression. Describe obstructive sleep apnea (OSA), its physiological mechanisms and treatment options. Answer: obstructive sleep apnea (OSA) is characterized by intermittent airway obstruction during sleep, leading to disrupted breathing, fragmented sleep, and resultant daytime fatigue. Physiologically, OSA is due to the collapse of the upper airway structures, often exacerbated by factors such as obesity, anatomical abnormalities, or neuromuscular disorders. The consequences of OSA include hypoxemia, which triggers sympathetic activation and can lead to cardiovascular complications, including hypertension and arrhythmias. Continuous positive airway pressure (CPAP) therapy is the cornerstone of OSA treatment. CPAP functions by delivering a continuous stream of air, maintaining upper airway patency throughout the night, thus preventing apneic events. Studies have shown that CPAP not only improves sleep quality and daytime alertness, but also significantly reduces cardiovascular risks associated with untreated OSA. Alternative treatments include lifestyle modifications, positional therapy, and dental appliances, but CPAP remains the most effective intervention for moderate to severe cases. Adherence to CPAP is critical for maximizing benefits, hence education and support for patients to overcome challenges with compliance are essential components of effective OSA management. Discuss the stages of sleep and their significance. Answer: sleep is regulated by complex physiological processes that include two main states: NREM, non-rapid eye movement, and REM, rapid eye movement. Sleep, NREM sleep, consists of three stages, ranging from light sleep (NN) to deep sleep (NN), which is crucial for physical restoration and recovery. During NREM sleep, the body experiences decreased heart rate and blood pressure, facilitating restoration and recovery of physical energy. REM sleep, typically occurring about 90 minutes after sleep onset, is characterized by rapid eye movements, increased brain activity, and vivid dreaming. This stage is essential for cognitive functions, including memory consolidation, emotional regulation, and brain development. The cyclic nature of sleep stages allows for physical and psychological restoration. Disruption of these cycles, such as through insomnia or sleep disorders, can lead to significant impairments in cognitive function, emotional stability, and overall health. Understanding these stages emphasizes the importance of good sleep hygiene and addressing sleep disturbances proactively to maintain mental and physical well-being. Describe the physiological basis of circadian rhythms and associated disorders. Answer: circadian rhythms are innate biological processes that follow an approximately 24-hour cycle regulating various physiological functions, including sleep-wake cycles. These rhythms are primarily controlled by the suprachiasmatic nucleus (SEN) in the hypothalamus, which responds to light-dark cycles in the environment, thereby influencing the release of melatonin and cortisol, hormones that promote sleep and wakefulness, respectively. Common disorders related to circadian rhythm dysfunction include delayed sleep-wake phase disorder, where individuals experience significant delays in sleep onset, often leading to difficulty waking in the morning, and advanced sleep-wake phase disorder ASAP, where individuals fall asleep early in the evening and awaken in the early morning. These disorders can significantly impair daily functioning, requiring interventions such as light therapy, chronotherapy, or melatonin supplements to realign the internal clock with the external environment. Understanding and managing circadian rhythms are crucial for promoting optimal sleep health and overall quality of life. Explain cognitive behavioral therapy for insomnia, CBTI, and its effectiveness. Answer: cognitive behavioral therapy for insomnia, CBTI, is a structured program that helps individuals identify and change thoughts and behaviors that contribute to insomnia. It addresses underlying issues rather than simply alleviating symptoms. Key components include sleep restriction, where individuals limit their time in bed to increase sleep efficiency, and stimulus control, which reinforces the association between the bed and sleep by limiting non-sleep activities in bed. Cognitive restructuring challenges and modifies unhelpful beliefs about sleep, such as catastrophizing sleeplessness. Relaxation techniques reduce arousal and anxiety associated with trying to sleep. CBTI is preferred over pharmacologic treatments because it provides lasting benefits without the side effects associated with sleeping pills, which can lead to dependence or tolerance over time. Research indicates that CBTI can be as effective as medication for chronic insomnia, making it a first-line treatment choice. By focusing on behavioral and cognitive strategies, CBTI empowers individuals to regain control over their sleep and overall health. How can pediatricians effectively screen for common psychiatric disorders in children, and what follow-up steps should they take when a disorder is suspected? Answer: pediatricians can effectively screen for common psychiatric disorders using validated screening tools such as the Pediatric Symptom Checklist (PSC) or the Strengths and Difficulties Questionnaire (SDQ). These tools help identify children at risk for conditions such as ADHD, anxiety, and depression. If a disorder is suspected, the pediatrician should conduct a comprehensive evaluation, including a detailed history, clinical observation, and input from parents and teachers. Collaboration with mental health professionals is essential for diagnosis and treatment planning. Referral to child psychologists or psychiatrists may be necessary for specialized assessment and intervention. Follow-up should include monitoring treatment efficacy, side effects, and the child's overall well-being, while maintaining open communication with caregivers and educators to ensure a supportive environment. Describe the clinical features and management strategies for Alzheimer's disease. How do they differ from those of vascular dementia? Answer: Alzheimer's disease typically presents with gradual memory loss, difficulty with language, and disorientation. Patients often experience changes in personality and behavior as the disease progresses. Management strategies for AD focus on cognitive enhancement using cholinesterase inhibitors, e.g., donepezil, rivastigmine, and NMDA receptor antagonists, e.g., memantine. Additionally, supportive care and structured environments are crucial for patient well-being. Vascular dementia, in contrast, arises from cerebrovascular issues leading to cognitive decline. Patients may exhibit more abrupt changes in cognition and function, often correlating with strokes or transient ischemic attacks. Management involves addressing cardiovascular risk factors, optimizing blood pressure, and promoting healthy lifestyle changes along with cognitive rehabilitation. Understanding these differences is vital for accurate diagnosis and appropriate treatment planning. Mr. Anderson, a 16-year-old male, presents with significant weight loss and avoidance of meals, coupled with excessive exercise. What steps should his healthcare provider take to assess and manage his condition? Answer: in assessing Mr. Anderson, a healthcare provider should conduct a thorough evaluation, including a medical history, physical examination, and psychological assessment to confirm a diagnosis of an eating disorder, potentially anorexia nervosa, or an atypical presentation. Key steps include physical assessment. Measure height, weight, and vital signs. Assess for any medical complications, e.g., electrolyte imbalances, cardiovascular issues. Psychological assessment. Use standardized tools like the Eating Disorder Examination Questionnaire, EQ, to evaluate eating behaviors and attitudes. Multidisciplinary approach. Referral to a nutritionist for dietary counseling and a psychologist or psychiatrist specializing in eating disorders for cognitive behavioral therapy (CBT) is crucial. Family involvement. Involve family members in therapy sessions to improve support systems and address familial dynamics that may contribute to the disorder. monitoring, regular follow-ups to assess weight restoration and psychological recovery, adjusting the treatment plan as necessary. Discuss the importance of suicide risk assessment in adolescents with mood disorders and outline the components of a comprehensive assessment. Answer: suicide risk assessment in adolescents with mood disorders is critical due to their heightened vulnerability to suicidal thoughts and behaviors. The assessment should be multifaceted and include the following components: clinical interview, directly inquire about suicidal ideation, plans, and past attempts. Use open-ended questions to facilitate discussion. Risk factors, evaluate for factors such as family history of suicide, psychiatric comorbidities, e.g., depression, substance abuse, and recent psychosocial stressors, e.g., loss, bullying, protective factors. Identify strengths and supports such as family ties, friendships, and coping mechanisms that could mitigate risk. Standardized tools. Employ risk assessment tools like the Columbia Suicide Severity Rating Scale, CSRS, to systematically evaluate suicide risk. Safety planning. Develop a safety plan involving coping strategies, emergency contacts, and access to mental health resources. Continuous monitoring and follow-up are essential to adapt to changes in the adolescent's mental health status. What are the distinguishing features of conduct disorder compared to oppositional defiant disorder, and what evidence-based interventions are recommended for treatment? Answer: conduct disorder, CD, and oppositional defiant disorder, ODD, are both categorized as disruptive behavior disorders, but they differ significantly in severity and behavior. CD is characterized by more severe behaviors, including aggression toward people or animals, destruction of property, deceitfulness, or serious violations of rules. These behaviors often lead to significant impairment in social, academic, or occupational functioning. ODD, on the other hand, includes less severe oppositional behaviors such as defiance, argumentativeness, and vindictiveness, but does not involve the more serious transgressions seen in CD. Evidence-based interventions for CD include multisystemic therapy (MST), a family-oriented, intensive approach addressing the various factors influencing the child's behavior. Cognitive behavioral therapy (CBT) helps children learn to manage their emotions and develop positive problem-solving skills. Parent management training (PMT) educates parents on effective discipline techniques and ways to reinforce positive behavior. Analyze the role of screening and brief intervention (SBI) in addressing substance use in adolescents and provide an overview of effective techniques. Answer: screening and brief intervention (SBI) is a crucial approach for addressing substance use among adolescents, aiming to identify and reduce risky behaviors before they escalate. The SBI process generally involves screening tools. Utilize validated tools like the CRAFFT screening tool to identify substance use patterns and risks. Assessment of severity. Determine the extent of use, consequences, and readiness to change using motivational interviewing techniques. Brief intervention. Engage in a non-confrontational conversation that explores the adolescent's attitudes towards substance use and encourages self-reflection on their behaviors. Effective techniques include motivational interviewing, a client-centered approach that fosters intrinsic motivation to change by exploring ambivalence and enhancing self-efficacy. Psychoeducation, educating the adolescent and family about the risks associated with substance use and the benefits of abstinence. Goal setting, collaboratively setting achievable goals for reducing substance use and enhancing healthy coping strategies. Explain the significance of understanding developmental milestones in assessing child development and identify red flags that may indicate the need for further evaluation. Answer: understanding developmental milestones is crucial for assessing child development as it provides a framework for recognizing typical versus atypical growth in various domains. Cognitive, social, emotional, and physical milestones vary by age and include skills such as language acquisition, motor skills, and social interaction. Red flags that indicate the need for further evaluation include cognitive, lack of babbling by 12 months, no single words by 16 months, or inability to follow simple directions by 2 years. Social, no eye contact, lack of interest in peer interactions, or not engaging in imaginative play by age 3. Emotional, inability to regulate emotions, persistent sadness, or extreme behavioral outbursts beyond expected age ranges. Physical, delays in gross or fine motor skills, such as not walking by 15 months or inability to stack blocks by age 2. Early identification of developmental concerns allows for timely intervention and support, optimizing outcomes for affected children. What are some strategies for differentiating oppositional defiant disorder from age-appropriate oppositional behavior in children, and how does the diagnostic approach differ? Answer. Differentiating ODD from normal oppositional behavior involves assessing the frequency, persistence, and impact of defiant behaviors. In ODD, behaviors are more severe, occur across multiple settings, and significantly impair functioning in school, social, and family settings. Key considerations include severity and duration. ODD behaviors are persistent and typically last at least 6 months, while age-appropriate defiance is usually situational and transient. Impact on relationships. Children with ODD struggle with authority figures and peer relationships, often displaying antagonistic behaviors beyond typical frustration or anger. Behavioral patterns. Clinical diagnosis requires a pattern of at least 4 symptoms, such as irritability, argumentativeness, defiance, or vindictiveness. Treatment for ODD involves behavioral therapy focusing on enhancing social skills and parent management training to reinforce positive behaviors and reduce negative interactions. What are the critical steps in the management of an acute psychiatric emergency, such as a suicide attempt or severe agitation, and how can a clinician assess the need for hospitalization? Answer. Managing an acute psychiatric emergency involves several critical steps aimed at ensuring the safety of the patient and others. The following approach is recommended. Safety assessment. The clinician should first assess the immediate danger to the patient and others. This includes evaluating the risk of self-harm or harm to others. Stabilization. In cases of severe agitation, physical restraint may be necessary to prevent harm. The use of rapid-acting sedatives, e.g. benzodiazepines, can help in calming the patient. Medical evaluation. A thorough medical evaluation should be performed to rule out any underlying medical conditions or substance use that may be contributing to the psychiatric crisis. Mental status examination. A comprehensive mental status examination is essential to assess the patient's cognitive function, mood, and thought processes. Assessing hospitalization needs. Factors to consider for hospitalization include severity of suicidal ideation or attempts, lack of support or resources at home, inability to ensure safety due to impulsive behavior, need for intensive psychiatric treatment that cannot be provided in an outpatient setting. If hospitalization is indicated, the clinician should facilitate admission to a psychiatric facility, ensuring continuity of care and follow-up. Describe the mechanisms of action and side effects of common classes of antidepressants, including SSRIs and ANRIs. Answer. Antidepressants are categorized into several classes, with selective serotonin reuptake inhibitors (SRIs) and serotonin norepinephrine reuptake inhibitors (NRIs) being among the most commonly prescribed. SSRIs, e.g. fluoxetine, sertraline. Mechanism of action. SSRIs inhibit the reuptake of serotonin 5-AT in the presynaptic neuron, increasing serotonin levels in the synaptic cleft and enhancing mood. Side effects. Common side effects include gastrointestinal disturbances, sexual dysfunction, insomnia, and increased anxiety during initial treatment. SNRIs, e.g. venlafaxine, duloxetine. Mechanism of action. SNRIs inhibit the reuptake of both serotonin and norepinephrine, providing a dual action effect that can be beneficial in treating major depressive disorder and anxiety disorders. Side effects. Side effects may include hypertension, particularly with venlafaxine at higher doses, nausea, dizziness, and sexual dysfunction. What are the key characteristics of borderline personality disorder, BPD, and how do treatment strategies differ from those for narcissistic personality disorder, NP? Answer. Borderline personality disorder, BPD, is characterized by pervasive instability in interpersonal relationships, self-image, and emotions. Key features include intense emotional responses, fear of abandonment, impulsivity, and recurrent suicidal behavior. Individuals with BPD may experience significant mood swings and have difficulty managing anger in relationships. Treatment strategies for BPD often involve dialectical behavior therapy, DBT. This is a specialized form of cognitive behavioral therapy designed to help individuals with BPD develop coping skills, emotional regulation, and interpersonal effectiveness. Medication. Antidepressants and mood stabilizers may be used to address specific symptoms, although no medications are specifically approved for BPD. In contrast, narcissistic personality disorder, NPD, is characterized by a pattern of grandiosity, need for admiration, and lack of empathy. Treatment approaches typically include psychodynamic therapy, focused on increasing self-awareness and understanding the underlying issues driving narcissistic behaviors. Cognitive behavioral therapy, CBT, aimed at modifying maladaptive thinking patterns and behaviors related to self-image and interpersonal relationships. While both disorders benefit from psychotherapy, the focus of treatment differs significantly due to the nature of the personality traits involved. A 32-year-old female with a history of epilepsy is experiencing severe depressive symptoms. What considerations should the psychiatrist make when selecting an antidepressant for her treatment? Answer: when treating a patient with epilepsy and depressive symptoms, the psychiatrist must consider the unique risks associated with certain antidepressants, particularly their potential to lower seizure thresholds. Many patients with epilepsy experience comorbid psychiatric disorders, particularly depression. SSRIs such as fluoxetine or sertraline are generally preferred due to their relatively favorable side effect profiles and minimal risk of inducing seizures. In contrast, bupropion is often avoided due to its association with an increased risk of seizures. Management requires a collaborative approach with neurologists to monitor seizure activity closely and adjust antiepileptic medication as necessary. Cognitive behavioral therapy (CBT) can also be beneficial as it addresses both the depressive symptoms and the psychosocial impacts of living with epilepsy, thereby improving the patient's overall well-being and adherence to treatment. Answer: the psychiatrist should prioritize assessing for delirium, which is characterized by an acute and fluctuating change in cognition and awareness. In hospitalized patients, especially those with multiple medical comorbidities like Mrs. Alvarez, delirium is a common complication often triggered by infections, medications, or metabolic disturbances. An initial assessment should focus on identifying any underlying causes contributing to her symptoms, such as pneumonia, electrolyte imbalances, or hypoxia. A thorough medical history, vital signs, and laboratory tests including CBC, electrolyte panels, and possibly imaging like a CT scan if warranted, should be conducted. Treatment of the underlying medical condition, in this case addressing the pneumonia, is essential. In the meantime, supportive care measures such as ensuring a calm and safe environment and reorienting the patient can significantly help in managing her confusion. Antipsychotics may be considered if she exhibits severe agitation or distress, but only with careful monitoring to avoid exacerbating any underlying medical issues, particularly in older adults with cardiovascular conditions. A 27-year-old man is brought to the emergency department in a state of acute mania, exhibiting severe agitation. What immediate pharmacological interventions should be considered for his stabilization? Answer: in cases of acute mania accompanied by severe agitation, rapid stabilization of the patient is critical. Antipsychotics, especially atypical ones like olanzapine or ziprasidone, are often used for their sedative properties and efficacy in rapidly reducing manic symptoms. Lithium, while effective for long-term mood stabilization, does not act quickly enough to address acute mania and carries risks of toxicity, particularly if hydration is compromised. Non-pharmacologic strategies, including verbal de-escalation techniques, should also be employed where appropriate, but if the patient poses a risk to themselves or others due to severe agitation, pharmacologic intervention becomes necessary. The emergency psychiatrist must continually assess the patient's response to medications and consider the need for further intervention, which may include a more comprehensive psychiatric evaluation once the acute symptoms are controlled. Mr. Thompson has been diagnosed with somatic symptom disorder. What are the best practices for managing his condition, particularly in a primary care setting? Collaborative care models between psychiatry and primary care are vital for managing chronic illnesses accompanied by psychiatric conditions. Patients with chronic diseases like diabetes often experience high rates of depression, which can significantly impact their ability to manage their medical condition, leading to poorer outcomes. A team-based approach fosters open communication between providers, allowing for shared decision-making regarding the patient's care. This may include regular screening for depression during routine medical visits, immediate referrals to mental health services, and the integration of treatment plans that address both physical and mental health needs. Studies show that such collaboration can enhance patient adherence to treatment regimens, improve mental health outcomes, and reduce overall healthcare costs by minimizing emergency room visits and hospitalizations. The involvement of behavioral health specialists in the primary care setting can facilitate early identification and intervention for depressive symptoms, which is crucial in improving the overall quality of life for patients managing chronic illnesses. When assessing a 45-year-old man with acute psychosis, what steps should the psychiatrist take to differentiate between possible organic causes and primary psychiatric disorders? Answer: when assessing Mr. Thompson's acute psychosis, the psychiatrist must prioritize a comprehensive medical evaluation to rule out organic causes. This includes considering potential toxicological factors such as substance use, which can often present with sudden changes in behavior, paranoia, and hallucinations. A detailed medical history focusing on recent health changes, substance use, or any other psychological stressors is critical. Diagnostic tests, including urine toxicology screening and blood work, including electrolytes, renal function, and liver function tests, should be initiated to identify any underlying medical conditions. It's also essential to assess for signs of infections, neurological disorders, or metabolic disturbances that might contribute to psychotic symptoms. Only after these potential organic causes have been ruled out should the focus shift to psychiatric diagnosis. This careful approach ensures that appropriate treatment interventions are applied, minimizing the risk of misdiagnosis and subsequent treatment delays. What is the role of collaborative care in managing chronic illnesses that are often accompanied by psychiatric disorders? Collaborative care models between psychiatry and primary care are vital for managing chronic illnesses that are often accompanied by psychiatric conditions. Patients with chronic diseases such as diabetes, cardiovascular disease, or chronic pain frequently experience comorbid psychiatric disorders like depression and anxiety, which can complicate their medical treatment and worsen their overall health outcomes. An integrated care approach ensures that both physical and mental health needs are addressed. This may involve regular mental health screenings during routine medical visits, providing educational resources about the relationship between chronic illness and mental health, and facilitating referrals to mental health specialists as needed. Studies show that collaborative care can enhance adherence to treatment regimens, improve mental health outcomes, and reduce healthcare costs by minimizing emergency room visits and hospitalizations. Through open communication between healthcare providers, patients receive comprehensive care that addresses both their psychological and physical health, thereby improving quality of life. Which factors are most indicative of imminent suicide risk in a patient presenting with suicidal ideation? Answer: in assessing a patient with suicidal ideation, several key factors indicate an imminent risk of suicide. These include access to lethal means, such as firearms or medication, and the presence of a specific suicide plan detailing when, where, and how the patient intends to carry out the act. A history of previous suicide attempts, particularly with high lethality, increases risk significantly. Additionally, psychiatric conditions such as severe depression, bipolar disorder, or substance use disorders exacerbate vulnerability. The assessment should also consider situational stressors, such as recent losses, relationship problems, or acute psychiatric crises. The emergency psychiatrist must conduct a thorough suicide risk assessment, utilizing validated tools, and implement immediate safety measures to protect the patient, which may involve hospitalization or close monitoring, while also providing support and appropriate therapeutic interventions. How should a psychiatrist approach a patient diagnosed with conversion disorder to ensure effective treatment and understanding of their symptoms? Answer: when consulting on a patient with conversion disorder, the psychiatrist should adopt a sensitive and informative approach to discussing the diagnosis. It is vital to communicate that the symptoms, such as paralysis, non-epileptic seizures, or sensory disturbances, are genuine experiences for the patient and are not indicative of a lack of effort or feigning. The psychiatrist should explain that these symptoms arise from a complex interplay of psychological and physical factors, often linked to stress or trauma, but without identifiable neurological causes. Using straightforward language and avoiding medical jargon can help the patient feel more comfortable. The treatment approach typically includes a multidisciplinary strategy combining psychotherapy, particularly cognitive behavioral therapy, with physical rehabilitation to address both psychological and physical aspects of the disorder. Encouraging the patient to engage in physical therapy or occupational therapy can facilitate symptom resolution and improve quality of life, empowering the patient through understanding and management of their condition. Ecopsychiatric emergency. What ethical considerations should guide the use of pharmacologic restraints? Answer: the ethical use of pharmacologic restraints in psychiatric emergencies is governed by principles of necessity and proportionality. Restraints should be employed only as a last resort when there is an imminent risk of harm to the patient or others, and when less restrictive interventions have been exhausted. The psychiatrist must ensure that the use of restraints is justified, documented, and regularly reviewed. Patients have the right to receive treatment in the least restrictive environment possible, and all measures should be taken to minimize the duration of restraint. Furthermore, informed consent and ongoing assessment are critical to ensure the patient's dignity and rights are respected. In cases where restraints are necessary, a multidisciplinary approach involving nursing staff and legal guidance can help uphold ethical standards and protect patient rights during crisis interventions. What strategies should a psychiatrist employ when consulting on a patient with conversion disorder to foster understanding and management of the condition? When consulting on a patient with conversion disorder, the psychiatrist should focus on fostering a supportive therapeutic relationship that emphasizes understanding and compassion. Explaining the nature of conversion disorder is crucial. The psychiatrist should convey that the symptoms are real, caused by psychological distress rather than intentional malingering. Incorporating psychoeducation into the treatment plan can demystify the disorder for the patient, helping them understand the relationship between stress, trauma, and physical symptoms. It is beneficial to normalize their experiences while reinforcing that recovery is possible with appropriate interventions. Implementing a multidisciplinary approach, including psychotherapy like cognitive behavioral therapy and physical rehabilitation, can address both the psychological and physical aspects of the disorder. Engaging the patient in setting treatment goals and encouraging participation in therapeutic activities can empower them, leading to improved outcomes and a better understanding of their condition.